Practical Pharmacokinetics, Part 5, Clinical Monitoring. Let's pick up from where we left off last time and discuss what direction do we go from here. We completed discussing the Bayesian approach, and so now we will move on and talk about the other two choices for our future direction. So why can't we just continue to use trough levels? Well, it's not reasonable to expect a single point to represent the entire AUC. AUC is reflective of the cumulative exposure for a defined time. The trough is only one single point measurement at the end of the dosing interval. Also, without drawing a second level, you're always estimating the volume distribution. By assuming the VD is 0.7 liter per kilo, you're not getting an accurate AUC measurement. How about using a new approach, the linear trapezoidal method? We can use simple kinetic equations to accurately estimate the AUC using the linear trapezoidal rule. Two steady-state vancomycin levels are collected, either the peak and trough or two post-infusion levels. Using first-order kinetic equations, we can first determine the elimination rate constant, then calculate the AUC using the area of two trapezoids. The advantage is that this dosing method can be easily applied at the bedside with a handheld calculator. Here's the concentration time profile of a vancomycin dose given at steady state. The dose is infused over 1 hour, and the drug undergoes alpha distribution over the following 1 hour, followed by beta elimination. The goal is to measure the area under the curve, or AUC, that's represented in the green color. You might be wondering, what's a trapezoid? A trapezoid is a four-sided figure with two sides that are parallel. The goal of this method is to build two trapezoids in the concentration time curve to calculate the AUC. One of the disadvantages is that there's a portion of the concentration time curve whose area is not captured by this method. So let's go ahead and build the trapezoids. So how do we build the trapezoids? Well, we first draw peak and trough levels, then we move the trough over if we need to, and then we solve for the KEL. Then we use the KEL to extrapolate the peak, and then we use the KEL to extrapolate the trough if we need to. Then we use the extrapolated points of Cmax and Cmin to build the two trapezoids. We then calculate the AUC using the following formula. AUC equals the time of infusion times the sum of Cmax and Cmin divided by 2 plus Cmax minus Cmin divided by KEL, all times the number of doses per day. Let's try an example of calculating the AUC using levels. Vancomycin peak and trough level results are available. The patient is on vancomycin 750 milligrams every 8 hours. Vanco levels drawn around the fourth dose are as follows. The vanco trough level drawn at 0.555 is 20. Vancomycin was infused from 0.600 to 0.700, and the vanco peak level was drawn at 0.930, and that value was 30. Calculate the AUC and determine what the new vancomycin dose should be. First, we plot out the measured C peak and C trough and move the C trough across if needed. We then calculate the KEL, which would be the log of 30 minus the log of 20 divided by 4.5, which is the difference in time between the two levels. The K calculates out to 0.09, and the half-life is 7.7 hours. We then use the KEL of 0.09 to extrapolate the level at the end of the infusion, which we'll call Cmax. That value is 37.5. We then use the extrapolated peak called Cmax, the extrapolated trough, which is Cmin, and the KEL to calculate the AUC. So the 24-hour AUC would be 1 times 37.5 plus 20 divided by 2 plus 37.5 minus 20 divided by the K 0.09 times 3 because we're giving 3 doses per day. And so the AUC 24 calculates out to 669. The 24-hour AUC of 669 is above the desired value of 400 to 600. Therefore, we need to reduce the dose of 750 milligrams every 8 hours. We do this by using basic mathematical ratios, and we come up with doses of 500 milligrams every 8 hours for an AUC of 446, or a dose of 750 milligrams every 12 hours to give us the same AUC of 446. Note that for both doses, the total amount of vancomycin that's delivered over a 24-hour period is 1,500 milligrams. What about initial empiric dosing? Can we solve for the AUC when starting a patient on vancomycin? Let's try an example. Here's the same patient with cellulitis that we saw in part 4. We begin by calculating out her pharmacokinetic parameters. For method 1, we solve for the dose and estimated peak and trough, which comes out to be a dose of 1,000 milligrams every 12 hours. We then apply a new fundamental kinetic equation that we need to memorize, which is AUC equals 24-hour dose divided by the clearance of vancomycin. When we apply this to the case, we solve for the AUC, which would be 2,000 milligrams divided by 4.5, coming up with an AUC of 444. Don't forget to give a loading dose of 1,750 milligrams initially. In method 2, we'll calculate the pharmacokinetic parameters as before. However, instead of estimating a new dose and peak and trough levels, we use our new formula to solve for the dose, which would be the AUC that we set at 450 times the vancomycin clearance of 4.5, and we get a dose of 2,025 milligrams. Since the tau is Q12 hours, we divide the dose by 2, and we get 1,012 milligrams, so we'll round the dose to 1,000 milligrams and get a dose of 1,000 milligrams every 12 hours, which will give us the same peak of 28 and a trough of 11.4. Also, don't forget to give a loading dose of 1,750 milligrams. So which future method is best for you? So of the 3, whatever method you choose, you'll need to take into consideration all the information that we presented in this video and determine for yourself and your colleagues what will work best at your institution. Keep in mind 2 very important points. Number 1, make sure to apply optimal antimicrobial stewardship. Vancomycin is frequently ordered inappropriately, and so by discontinuing the unneeded vancomycin, you can avoid the time required for kinetic dosing, drawing levels, and doing the analysis. The second important thing to remember is to rely on your loading doses. Routine use of a loading dose rapidly attains effective drug exposure, so achieving maximal AUC-MIC levels is most critical on days 1 and 2. It's foolish to draw levels to calculate AUC exposure in the first 1 to 2 days, since the vast majority of patients treated with vancomycin don't require therapy beyond 48 to 72 hours. Let's move on and talk about some daily monitoring tips. What are some important parameters that we can use to monitor patients on antibiotics? Well, we can look at the patient's allergies, their temperature, their white count, their BUN serum creatinine, their inputs and outputs and urine output, their cultures and sensitivities, and a new one, Procalcitonin, which we'll discuss in a few slides. What important considerations should I make when I start a patient on per pharmacy vancomycin or aminoglycosides? It's very important to check the entire medication profile to see if any prior doses were given. This is especially important for dialysis patients. And it's also important to check the emergency record too to see if any medications were given in the emergency room. One thing to be on the lookout for is a patient that has a weight that's recorded as greater than 100 kilograms. If that's the case, make sure that you verify that the patient is overweight or obese by either scanning the medical record or by looking at the patient. The nurse may have entered the wrong weight in the computer system, using 100 kilograms instead of 100 pounds. This can result in a critical dosing error of more than twofold. When scheduling antibiotics, avoid scheduling penicillins and cephalosporins like pip/tazo at the same administration time as aminoglycosides due to a drug-drug interaction. In vitro, the beta-lactam ring on penicillins reacts with the amino groups on the aminoglycoside to form biologically inactive amides. Thus, both antibacterials are inactivated. When scheduling times for drug levels to be drawn, it's always good to schedule them in the morning time around 0500 or 0600. This is better because more phlebotomists and day lab technicians are around. Also, the day shift pharmacist can follow up on the levels instead of leaving it for the evening or night shift crew to take care of. Also, levels don't have to be scheduled exactly around the third dose or before the fourth dose. Levels can be delayed until the next morning for convenience. What could be reasons for measured drug levels to be lower or higher than predicted values? When drug levels are back but are lower than expected, the three main reasons why would be missed dose or doses, improved renal function, or the level was drawn at an incorrect time. The table lists some additional reasons why drug levels are lower than expected. When drug levels are back but are higher than expected, the three main reasons why would be worsening renal function, the level was drawn at an incorrect time, or the lab drew a sample out of a central line port or through the drug administration line that was improperly flushed prior to the sample withdrawal. For patients who require longer durations of vancomycin, it's important to note that the drug will accumulate in the tissues. Due to this accumulation, make sure to check a trough level at least once a week. Aminoglycosides can cause nephrotoxicity, and the characteristics of this nephrotoxicity is that it's a non-oliguric renal failure, it's associated with trough levels greater than 2, it takes at least 3 days of therapy to show up, and it is reversible. Another known side effect of aminoglycosides is its neurotoxicity, and it can cause neuromuscular blockade. Vancomycin can cause what is known as red man syndrome. The characteristics of this syndrome is a red, itchy rash in the face, neck, or upper torso. It's caused by histamine release. It's usually due to a rapid infusion rate of vancomycin, and so it's important to infuse doses of 500 milligrams to 1 gram over at least 1 hour. Let's talk a little bit about a new monitoring parameter called procalcitonin. So what is procalcitonin? Procalcitonin is a biomarker for bacterial infection. In response to the presence of a bacterial infection, procalcitonin production is stimulated. Cytokines stimulate procalcitonin production and trigger its release from immune and parenchymal cells of tissues. It's important to note that viral infections do not increase procalcitonin levels. Here's a table that shows that bacterial infection is very likely if the procalcitonin level is above 0.5, and infection is likely if the procalcitonin level is between 0.25 and 0.5 nanograms per ml. This figure shows that sepsis and local infection is associated with the procalcitonin level starting at 0.5 nanograms per ml. So where can we use procalcitonin? We can use it to improve the diagnosis of bacterial infections and use it to differentiate between bacterial infections and viral infections. Procalcitonin can also help us track the clinical progress of a patient's infection and can help assess the continued need for antibiotics when the infection is resolving. It can be used to shorten antibiotic treatment duration by early cessation of therapy and de-escalation. One limitation of procalcitonin is that it can be falsely elevated in acute and chronic renal failure, after surgery, and in patients with severe trauma or major burns. Fungal infections may also result in elevated procalcitonin, but to a lesser extent. Procalcitonin is safe to use without evidence of any kind of increased risk of mortality, recurrence, or treatment failure. Special populations of patients have unique characteristics that we need to take into consideration. One group are spinal cord patients. We know that we need to be very careful with these patients and treat them like an elderly patient with poor muscle mass, but possibly much worse than that. These patients have muscle atrophy, a loss of muscle mass, low production of creatinine, so don't assume a low serum creatinine is normal. In nephrectomy patients with removal of one kidney, we need to reduce the calculated creatinine clearance by 25%. And patients with ascites who are treated with aminoglycosides tend to have increased volumes of distribution to 0.5 liter per kilo. What do we do for patients who have had amputations? We determine the height based on the ideal body weight before the amputation, and then we subtract the percent of the missing limb based on the data from the body segment percentage table that you see below. How do we dose vancomycin in hemodialysis patients? During hemodialysis, vancomycin doses must be individualized. Why? Because there's interpatient variability. Here are some factors for interpatient variability. During hemodialysis, drug removal is affected by numerous variables, including dialysate and blood flow rates, positive and negative pressures, and length of dialysis. Vancomycin is not substantially dialyzed by low-flux hemodialysis membranes, but it is cleared substantially by newer high-flux, high-permeability membranes, 30 to 40%, over a standard 3 to 4 hour hemodialysis session. For non-critically ill patients receiving hemodialysis, 2 or 3 days is the most common interdialytic period. Some patients in the ICU may require dialysis daily for a few days. Anuric, non-anuric. Is the patient able to make urine, or are they totally anuric? So how do we dose vancomycin in hemodialysis? Well, there's no real standardized approach that's accepted by everyone. So we'll use the simple bolus method. We give a dose and we check a level. Depending on the resultant level, we can then determine how the patient is eliminating the drug. We can then rebolus the patient back to the desired level to achieve a consistent desired trough. Here are my recommendations. Give an initial loading dose of vancomycin 20 to 25 mg per kilogram for an estimated level of 28 to 35 micrograms per mil. On the days of the next 2 hemodialysis sessions, a pre-dialysis vancomycin level should be drawn with the morning lab tests to guide dosing. Maintaining pre-dialysis concentrations between 15 and 20 micrograms per mil will likely attain the AUC target of 400 to 600. This is per 2020 vancomycin consensus guidelines. When you get the level back, depending on the value of the level, a supplemental dose can be given after dialysis. See the sample nomogram on the next slide. Depending on the size of the patient, the vancomycin maintenance doses will typically range from 500 to 1,000 milligrams after each hemodialysis session, or about every 3 to 4 days. Once a patient has 2 consecutive therapeutic pre-dialysis concentrations, a weekly pre-dialysis vancomycin concentration can be considered. Here's an example of a dosing algorithm for vancomycin in hemodialysis patients. A loading dose of 20 to 25 mg per kilogram is initially given. then a pre-dialysis level on the morning of the scheduled session is drawn. Depending on the value of that level, a supplemental dose of vancomycin is given. Pre-dialysis levels are continued to be drawn until a consistent value of 15 to 20 micrograms per ml is achieved. For aminoglycosides, the recommendations for hemodialysis are quite a bit more easier. For gentamicin and tobramycin, we give a loading dose of 2 mg per kilogram, and then we give 1 mg per kilogram after each hemodialysis session. For amikacin, it's 7.5 mg per kilogram as a loading dose, and then 3 to 4 mg per kilogram after each hemodialysis. These dosing regimens generally work well when the conventional dialysis lasts about 3 to 4 hours and occur 3 to 4 times a week. Modifications to the dosing regimens could be required when deviations from the above dialysis sessions occur. Let's go over what we learned in Part 5. We described how to use the linear trapezoidal method of vancomycin dosing to calculate the AUC-MIC ratio with examples. We listed important clinical tips to consider when performing daily monitoring, including using procalcitonin. We identified how to deal with special populations, such as patients with amputations, and we outlined how to dose vancomycin and aminoglycosides in hemodialysis patients. We've got a lot in store at the PharmEasy Tutor channel. There will be upcoming talks on treatment of multi-drug resistant organisms, TPN, electrolyte management, code blue emergencies, management of acute heart failure, quinolone side effects, and much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.